Imagine a patient presenting with persistent shoulder pain. It looks, for all the world, like a classic impingement scenario, yet something feels, well, a bit off. Standard treatments just aren't quite hitting the mark. What if the underlying cause is an anatomical variation, one that's often overlooked? A subtle structural quirk. Welcome to Deep Dive Ortho. This is where we unpack complex topics in orthopedic surgery, aiming to give you insights that hopefully truly matter for your daily practice. Today, we're embarking on a really crucial deep dive into a fascinating, yet sometimes rather elusive condition, acromiale. We'll explore its developmental origins, its high-day varied clinical impact, and the latest diagnostic and treatment approaches. The goal is really to help you refine your diagnostic eye and perhaps sculpt your treatment strategies for better patient outcomes. Welcome to Deep Dive Ortho. This is where we unpack complex topics in orthopedic surgery, aiming to give you insights that hopefully truly matter for your daily practice. Today, we're embarking on a really crucial deep dive into a fascinating, yet sometimes rather elusive condition. Now, also, acromiale, while it's frequently just an incidental finding on imaging, it can, when symptomatic, become a significant and challenging cause of shoulder pain and disability. Our mission today is to transform your understanding of this anomaly into clear, actionable knowledge. To guide us through these intricate details, we are joined by Professor Mo Imam, a distinguished expert who brings extensive clinical experience and a really profound understanding of orthopedic research to our discussion. It's a real pleasure to have you with us.
Thank you. It's a pleasure to be here. It's certainly a condition that presents a diagnostic dilemma quite frequently, so I'm keen to share some practical insights.
Absolutely. So let's start right at the beginning. For those perhaps less familiar with the absolute specifics, what exactly is an acromiale? Can you give us a precise definition and maybe set the stage for its developmental journey?
Certainly. At its core, an acromiale is essentially an unfused secondary ossification center of the acromion. It's fundamentally a developmental anomaly, a failure, really, in the normal process of bone formation.
Okay.
You can think of it this way. The acromion, that crucial bony roof over the shoulder joint, a protective arch, if you like it, doesn't develop as a single piece of bone right from the start. Instead, it forms from several distinct ossification points or centers that emerge over time.
Right.
And in typical development, these centers are designed to gradually merge, to unite, forming a single solid bony structure.
So it's a failure of what should be a seamless fusion process. When does this fusion normally happen? And I suppose at what point does non-fusion become, well, pathological?
Precisely. That critical fusion process usually completes between the ages of 15 and 18 years. Though it's important to remember that complete ossification, where all four centers have fully merged, can sometimes occur as late as 25 years of age.
25, really. Yeah.
Yes. So an acromiale arises when this expected bony union doesn't complete after that typical age range. And what you're left with, instead of solid bone, is a persistent fibrocartilaginous connection, or in some cases, even a distinct synovial joint, which creates a pseudoarthrosis.
A false joint, effectively.
Exactly. And this non-union can then become a source of pain and, importantly, mechanical dysfunction.
That paints a very clear picture of its origins. Now let's talk about prevalence. How common is this? Is it something that genuinely flies under the radar, or should we, as orthopedic surgeons, be expecting to see it fairly regularly? What do the stats tell us?
Well, it's surprisingly common, actually. There's a part of the clinical paradox we'll touch on shortly. The reported prevalence ranges quite widely in the literature, somewhere between 1% and maybe 15% in various radiographic and anatomical studies.
That's a big range.
It is. And some literature, particularly specific anatomical dissections or MRI studies in certain populations, even suggests figures possibly as high as 30%. This broad range often reflects the different diagnostic tools used and the specific populations being studied, of course.
Of course. 30% is quite high, though. And what about laterality? Is it usually just one side or often both?
That's another notable point and very important clinically. It's frequent bilateral involvement. It's found in approximately 60% of cases where it's present.
60%? Wow.
Yes. So if you diagnose an acromiale on one side, it's highly advisable to check the contralateral shoulder. There's a strong chance it's present there too, even if it's currently asymptomatic. This obviously has implications for patient counseling and thinking about future management.
Definitely something to bear in mind. And are there any specific demographic trends? Are certain populations more likely to have this anatomical variant?
Yes, there are quite distinct ones, actually. And this is where some interesting epidemiological data comes into play. Generally, it's observed to be more common in males.
Okay.
And furthermore, there's a statistically higher frequency observed in African American populations compared to individuals of white, Native American, or Middle Eastern ancestries. This racial disparity has been quite consistent across larger reviews.
That's quite striking.
It is. Now, it's worth noting there was some debate in earlier literature about gender bias, with some initial studies finding no significant difference. But the overall trend from more robust, larger reviews does lean towards higher male prevalence, and that racial disparity remains a consistent finding. The exact genetic or perhaps environmental factors behind these differences are still, well, subjects of ongoing research, really.
Fascinating. A subtle anatomical variant with such clear demographic patterns. So, despite this notable prevalence, you mentioned a clinical paradox earlier. Can you elaborate on that? Because it sounds like we might be seeing this quite often, maybe without even realizing its significance.
Yes, and this, I think, is a critical takeaway for everyone listening, what I call the Acromiale paradox. Despite being relatively common, found in a significant percentage of the population, as we've discussed, the vast majority of individuals who actually have an acromiale remain entirely asymptomatic throughout their lives.
Right.
It's frequently discovered just as an incidental finding when imaging the shoulder for completely unrelated reasons, perhaps after a fall or for suspected rotator cuff issues that turn out to be something else entirely.
So the mere presence of an acromiale doesn't automatically equate to pain or pathology. This immediately tells us that finding one on imaging isn't the end of the diagnostic journey, is it? It's really just the beginning.
Precisely.
Mm-hmm.
Our real challenge, and a key focus for us as clinicians,
Mm-hmm.
is distinguishing this benign anatomical variant, which causes no problems, from a true symptomatic acromiale that is the actual source of a patient's pain and disability.
Mm-hmm.
And here's another crucial point. A previously asymptomatic acromiale can, unfortunately, become symptomatic.
Mm.
This is often triggered by a specific event, perhaps an acute trauma like a direct blow to the shoulder, or maybe even chronic repetitive microtrauma from certain activities.
Okay.
These events can induce pain and instability at that non-union site, effectively transforming a silent anatomical anomaly into a painful, functionally limiting condition. And this is where the diagnostic challenge truly begins for us. We have to become, well, detectives.
We certainly do. So it's not just identifying its presence, but proving its role. And to really understand why it causes symptoms when it does, we need to get into its blueprint, as it were. Let's embark on that deeper exploration of the anatomy and pathophysiology. Can you walk us through the details of the acromions ossification centers and how they relate to the type of ossicromial we might encounter?
Absolutely. Understanding these centers is fundamental, really, both for classifying the condition and for comprehending its biomechanical implications.
Yeah.
The acromion, as we mentioned, isn't a single bone at birth. It forms from 4 distinct ossification centers. They appear sequentially and are meant to fuse. From anterior to posterior, these are first the preacromia.
The tip.
Exactly, that forms the very anterior tip.
Yeah.
Second, the mesoacromion, which is the middle segment, typically the largest, contributing significantly to the acromial body. Third, the metaacromion, forming the base. And fourth, the basiacromion, the most posterior bit, which eventually fuses with the scapular spine, forming that continuous bony arch.
Okay, 4 centers.
Yes. And the type of ossicromial is then classified based on the specific unfused segment that lies immediately anterior to the non-union site. This classification gives us a sort of topographical map of where the pseudoarthrosis is located.
That's incredibly helpful. So, for example, if the non-union occurs between the mesoacromion and the metaacromion, what type would that be? And importantly, which type is most commonly implicated when patients do have symptoms?
Right. If the non-union is between the meso and metaacromion, that's classified as a type A oasacromial. So that's called a mesoacromion. And this is by far the most prevalent type. It represents about 75% of all cases.
75%. Oh.
Yes. And it's often the one that causes the most clinical trouble. It's located right in the central portion of the acromion.
Right.
Then we have type B, which is a failure between the pre and mesoacromion, so that's more anterior.
Right.
And type C, or metacromial, which is failure between the meta and basiacromion, making it a more posterior lesion. And very rarely you can even see a double ossicromion with 2 non-union sites, essentially a combination.
Wow.
Understanding these types is crucial because the location influences the biomechanical forces acting on it and, therefore, the likely clinical presentation and the treatment strategy. For example, a mesoacromial, type A, often experiences significant deltoid pull, which really contributes to its instability.
Fascinating. So these fragments, instead of being solid bone, are connected by some kind of tissue. What does the microanatomy of that non-union site actually look like? What are the implications of those variations?
This microanatomy is vital, as it impacts the potential for mobility and consequently symptom generation. The connection can vary quite significantly. Firstly, it might be a synchondrosis,
Which is?
essentially a fibrocartilaginous union. Think of it like the soft connection in a child's graying skull.
Mm.
It offers some flexibility, some resilience, but it's not solid bone. Secondly, it could be a syndesmosis, which is a purely fibrous connection, often providing a slightly more rigid degree of stability. And then, at the most mobile end of the spectrum, and often the most problematic, it can even form a distinct synovial joint. This is essentially a true pseudoarthrosis, complete with a capsule, synovial fluid, maybe even articular cartilage surfaces.
Like a proper little joint.
Exactly. And this implies varying levels of mobility and, crucially, a significant potential for irritation, inflammation, and pain because of the constant micromotion and friction at this new joint. This variability is likely why some individuals remain completely asymptomatic, while others experience quite profound pain and dysfunction.
That range really highlights why some are silent and others are so problematic. Moving on to blood supply, what's crucial for us as orthopedic surgeons to bear in mind there, especially if we're considering any intervention.
The blood supply is absolutely critical,
Yeah.
particularly for anyone considering surgical intervention aiming for fusion. The primary blood supply to these acromial fragments comes from the acromial branch of the thoracoacromial artery. It's a relatively small but vital vessel. Preserving this blood supply during any surgical procedure, especially in ORAF, where the goal is bony union, is paramount to successful fusion and maintaining the vitality of the bone fragments.
So cutting it off is bad news for healing.
Absolutely. Severing it, which can unfortunately happen with certain overly aggressive approaches or extensive periosteal stripping, can lead to devascularization of the fragment. This makes bony union much less likely, potentially leading to ongoing non-union and persistent symptoms. This anatomical detail is really a non-negotiable consideration for surgeons.
So it's not just about fixing the bone, but preserving its lifeblood. Okay, let's turn to the heart of the matter for our patients. How does an osteoacromiale actually cause pain and dysfunction? What are the mechanical insights driving the symptoms?
This is where the biomechanics become incredibly relevant and help us understand the patient's experience. There are two primary, well-understood mechanisms by which an osteoacromiale can cause symptoms. Firstly, there's dynamic impingement. With an unstable osteoacromiale, particularly the more anterior fragments like the pre- or mesoacromion, the deltoid muscle, which attaches there, exerts significant pull. During arm elevation, especially forward flexion, the contraction of the deltoid can cause that anterior fragment to sort of pivot or flex downwards.
Like a flap dropping down.
Precisely. Imagine it as a flap of bone dropping into the space below. This effectively reduces the subacromial space, that critical tunnel where the rotator cuff tendons pass, leading to impingement on those underlying tendons and the subacromial bursa. It's a direct mechanical obstruction.
So a direct mechanical irritation, almost like a mobile osteophyte that isn't supposed to be there.
Exactly. And the second key mechanism is direct pain from the non-union site itself. The constant micromotion, the instability, the friction at this unfused pseudoarthrosis can generate pain, and it's often described as a painful synchondrosis or pseudoarthrosis. The continuous pulling forces of the deltoid muscle on these unfused segments, acting across what is essentially a fragile, irritated junction, can significantly exacerbate this discomfort. It's like a chronic stress fracture, in a way, but one that never properly heals because of the ongoing motion.
Right.
And this can lead to degenerative changes at the non-union site itself, things like sclerosis, cyst formation, further contributing to the pain.
Now, the relationship between acromial and rotator cuff tears, that's been a perennial point of debate, hasn't it? Some earlier studies suggested quite a strong link. What's the current understanding there? Has the consensus shifted?
You're right, it has been controversial, and our understanding has evolved. Early studies, often with smaller sample sizes or perhaps retrospective designs, did suggest a high incidence of full-thickness rotator cuff tears in patients with acromial, some quoted figures around 50%.
Which is very high.
Very high. And this led to the belief that the osteoacromiale was a primary driver of these tears. However, later, larger, more methodologically robust studies have re-examined this relationship with greater scrutiny. And what they found was quite enlightening. The average number of tendons involved in rotator cuff tears was surprisingly similar in patients with and patients without an osteoacromiale.
Ah, okay. So maybe not the direct cause we once thought.
It suggests the mere presence might not directly predispose to tears as broadly as once thought. It might simply be a coexisting condition in many cases, or the relationship is more nuanced.
But there is a specific association we need to be acutely aware of, isn't there? A particular morphological feature that does elevate the risk.
Indeed, and this is the vital nuance. Crucially, subjects with a step-off deformity of an os acromiale are at a significantly greater risk of rotator cuff tears.
A step-off deformity.
Yes. This isn't just about the presence of an unfused segment. It's about a malalignment. Imagine the inferior cortex, the bottom edge, of the os acromiale fragment being displaced downwards relative to the rest of the acromion. This creates a direct, bony projection, a palpable step that acts as a consistent mechanical irritant and impingement point against the rotator cuff tendons as they pass underneath.
So a sharp edge, essentially.
A sharp projecting edge. This particular malalignment appears to be a much more direct mechanical driver of tears than just the presence of an os acromiale without that step-off.
So it's the quality of the non-union, the morphology, not just its existence, that really matters for cuff pathology.
Precisely. Furthermore, it's important to note that rotator cuff tears are significantly more common in young throwing athletes who present with what we call acromial apophysiolosis.
Apophysiolosis.
Yes, this is essentially an early, painful non-fusion or a stress injury of the acromial growth plate in a skeletally immature or perhaps recently matured individual. In these athletes, the repetitive, high-stress overhead motions can cause microtrauma at the still-developing apophysis. This leads to a painful pseudoarthrosis and, yes, an elevated risk of rotator cuff pathology. It highlights the unique challenges in diagnosing and managing this in the athletic population.
That's a vital distinction for younger patients and athletes. It sounds like the diagnostic challenge overall is quite significant, especially given that many symptoms mimic other common shoulder conditions. What are the typical clinical presentations we should be looking out for? What will patients complain of?
You've hit on a critical point. The symptoms are often nonspecific, making it a true diagnostic puzzle. It's often confused with straightforward subacromial impingement or rotator cuff tendinopathy. Patients commonly report localized shoulder pain, specifically in the superior and anterolateral acromion area, right over that bony prominence.
Over point tenderness.
Yes. And this pain is almost universally exacerbated by overhead activities, repetitive use of the arm, reaching movements, and activities involving deltoid contraction, like lifting or pushing.
And beyond the pain itself, what about functional limitations? What will patients tell you they struggle with?
Absolutely. Along with the pain, patients often experience a noticeable decrease in their shoulder range of motion, particularly active elevation. They might describe a sense of generalized weakness in the affected arm and significant difficulty with everyday activities requiring arm elevation or lifting things like dressing, reaching high shelves, or participating in sports. And a classic complaint we frequently hear, one that should raise a red flag for you, is persistent night pain. It can be severe enough to profoundly disrupt sleep, especially when they try to lie on the affected side. That night pain can be a strong indicator of an inflammatory process or significant chronic irritation.
Night pain is certainly a strong indicator. On physical examination, what specific findings might steer us towards a diagnosis of symptomatic os acromiale?
On examination, you'll typically find tenderness to direct palpation right at the superior aspect of the acromion, directly over that non-union site. That point, tenderness, is a very telling sign.
Okay.
You'll also likely elicit positive impingement signs during specific shoulder movements. The NEAR test, Hawkins-Kennedy test, because, as we discussed, the unstable fragment often causes that dynamic mechanical impingement.
Right.
And in some cases, particularly with a very unstable fragment, you might even be able to palpate or feel an obvious movement or translation of the bony fragment relative to the rest of the acromion during passive or active shoulder motion.
You can actually feel it move.
Sometimes, yes.
Yeah.
And that palpable movement is, of course, a very strong, almost definitive indicator of instability.
That must be quite definitive when present. How do we start to filter this information then? Especially when so many conditions present similarly, and how do we differentiate it from, say, AC joint arthritis or straightforward rotator cuff tears?
The clinical evaluation remains a cornerstone, as always. A thorough physical examination, with a keen focus on those impingement signs and assessing the full range of motion, is our initial filter. And it's important to note a key differential diagnostic point here. If the os acromiale is not complicated by other extra-articular shoulder pathologies, meaning it's the sole source of pain, then the clinical examination of the rotator cuff itself, when tested in isolation, is typically normal.
Okay.
And importantly, palpation of the acromioclavicular joint, the ACJ, should not be painful. This helps you narrow down the pain generator. Is it the os, the cuff, or the ACJ?
But the truly critical diagnostic tool in the clinical setting, I understand, is a targeted injection. Can you elaborate on the role and technique of this diagnostic injection? How reliable is it?
Indeed. Perhaps the most critical diagnostic tool in the clinical algorithm for a suspected symptomatic acromial is that selective diagnostic injection. We perform an injection of 1% lidocaine, a local anesthetic, directly into the suspected non-union site,
Right into the gap.
right into the pseudoarthrosis. This needs to be precise, ideally guided by palpation if it's easily felt, or increasingly, under ultrasound guidance to ensure accurate placement. If the patient experiences significant, albeit temporary, pain relief, typically we look for 80% or more improvement following this injection. It's considered a strong indicator that the acromial is indeed the primary source of their symptoms.
Okay.
This helps us definitively differentiate it from other potential pain generators, like the subacromial bursa or the rotator cuff itself. It's a critical step, especially before considering surgical intervention.
So it's about isolating the pain generator. Beyond the clinical exam and this key injection, what imaging modalities do you recommend for confirming the diagnosis and characterizing the anomaly? Starting with plain x-rays.
For adults, plain radiographs are always the recommended initial imaging. They're readily available, cost-effective, and give a good initial overview. Specifically, the axillary lateral view is paramount.
The axillary view, okay.
Yes, because it provides the clearest, unobstructed visualization of the os acromial and the pseudoarthrosis. On the standard anteroposterior AP view, a useful clue you might spot is the double density sign.
Double density.
Yes, this appears when the cortical margin, the edge of the os acromial fragment, is superimposed over the base of the acromion at the non-union site. It creates a sort of denser, duplicated appearance on the film. It's subtle, but an important indicator to look for.
Good tip. And what about ultrasound? Is that helpful here, and what specific features can it reveal?
Yes, ultrasound definitely has its utility. It's rapid, non-invasive, and can be quite accurate. It can readily identify a pseudo-articulation at the non-union site, and importantly, it allows us to dynamically assess the mobility of the os acromial fragment during shoulder movement.
So you can see it move in real time.
Exactly. That real-time assessment of instability is a significant advantage. When examining with ultrasound, you might also observe 3 distinct sonographic types of bony margins at the non-union. They could be flat, they might show marginal osteophytes, or they could have inverted margins.
And what do those different margin types tell us?
Well, it's not just academic. Identifying these features gives clues. Flat margins might suggest less chronic instability, perhaps. Prominent marginal osteophytes often point towards long-standing irritation and degenerative changes, similar to what you'd see in osteoarthritis, suggesting it's been unstable for a while. Inverted margins, though less common, can indicate a very specific type of unstable articulation, perhaps more prone to catching or locking.
Interesting. For more detailed visualization, particularly of those degenerative changes, what's the role of CT scans and MRI?
CT scans are indicated when you need a more detailed three-dimensional look at the non-union site itself. They're excellent for accurately delineating the bony morphology and detecting subtle degenerative changes that might be missed on plain films, things like cysts, sclerosis, or hypertrophy, right at the unfused junction. These are telltale signs of chronic stress and instability.
And MRI.
Magnetic resonance imaging, or MRI, plays an even more critical role, I'd say, especially for symptomatic cases and in younger patients, where distinguishing normal development from pathology can be tricky. MRI can reveal characteristic features like an abnormal shape of the fragments, fluid-like signal intensity right at the interface between the fragments.
Like fluid in the joint.
Exactly. And crucially, marrow-edema along the opposing bone surfaces. Think of marrow-edema as a bone bruise. It's a powerful signal of acute or chronic stress and inflammation right at that unstable junction. It tells you this isn't just an incidental finding, it's likely an actively painful one.
Right.
And of course, MRI is invaluable for assessing any concurrent soft tissue pathology, rotator cuff tendonitis, partial tears, full-thickness tears, which are often present and contribute significantly to the patient's symptoms.
And finally, for those really challenging cases, particularly in younger patients, I understand SPECT-CT can be quite revealing. How does this advanced imaging help?
Indeed. SPECT-CT, specifically using 99 millisy MDP bone scintigraphy, is an advanced technique that can demonstrate increased metabolic activity, increased hotness at the affected acromion. This increased radionuclide uptake indicates ongoing osteoblastic activity and inflammation, which is highly consistent with a symptomatic osteochromial.
So it shows biological activity.
Precisely.
Okay.
It's particularly valuable in younger patients where incomplete fusion is still an active process. It can help differentiate a truly symptomatic lesion from normal developmental variation that might otherwise look similar on other imaging. It provides a physiological rather than just an anatomical view of what's happening at that non-union site.
That brings us neatly to that key point. Diagnosing this in adolescence, how does the diagnostic approach differ or become more nuanced for younger patients, given they're still developing skeletal system?
Yes, this is a specific and quite common diagnostic challenge in adolescents and young adults. Their acromion is still developing, with secondary ossification centers that may not yet have fully fused. So, trying to differentiate a normally developing acromion with its physiologically separate centers from an early, potentially symptomatic os acromial based solely on age and standard X-rays can be incredibly difficult.
You could easily miss it or overcall it.
Exactly. It often leads to misdiagnosis or delayed treatment. This is precisely where those unique features on MRI, the fluid signal, the marrow edema, frank instability become particularly valuable. Similarly, that increased activity on SPECT-TT can provide objective evidence of ongoing inflammatory or stress-related activity at the non-union. These findings help us accurately diagnose instability and symptom generation in a younger patient, guiding appropriate management rather than just waiting for skeletal maturity, which might allow further damage to occur in the meantime.
Thank you. That's a truly comprehensive look at the diagnostic maze. Now, once we've established a symptomatic osteochromial, how do we navigate the treatment pathways? What's the essential first step?
The essential first step and the general initial recommendation for patients presenting with a symptomatic osteochromial is non-operative therapy, conservative management first. This is particularly true for those with mild to moderate symptoms, or maybe those who present after an acute traumatic event and are still in that early inflammatory phase.
And what does that conservative approach typically involve? What are the components and how long do we typically try it for?
It's a multimodal approach, really, designed to reduce inflammation, alleviate pain, and restore function without surgery. We usually begin with a period of observation, combined with non-steroidal anti-inflammatory drugs, NSAIDs, for systemic pain and inflammation control. Local measures are also key. Subacromial corticosteroid injections can be very effective in reducing localized inflammation and symptoms, especially if there's an associated bursitis. But crucially, physiotherapy plays a vital and often prolonged role. Exercises should focus on a structured program. Stretching internal and external rotators can restore balanced mobility, strengthening muscles that help lower the humeral head to decompress the subacromial space, and significantly, strengthening scapular stabilizers, the serratus anterior, lower trapezius. A stable scapular platform is paramount.
Right, getting the whole shoulder girdle working properly.
Exactly. Adjunctive measures like rest, regular ice application, and modifying aggravating sports or occupational activities are also important. Reducing stress on the area allows the pseudoarthrosis to potentially stabilize or at least calm down. And in terms of duration, a typical trial of conservative treatment should usually be at least 6 months.
6 months minimum.
Yes, minimum. This allows sufficient time for the inflammation to settle and for the patient to really maximize the benefits of physiotherapy.
Okay, so after a robust trial of conservative measures, perhaps 6 months or more, when do we pivot to surgical considerations? What are the clear indications for operating, and what are the overarching goals?
Surgical intervention is clearly indicated when those conservative treatments, despite being diligently applied for that minimum period, have demonstrably failed to alleviate persistent symptoms. We're looking for ongoing, debilitating pain and functional limitation that significantly impacts the patient's quality of life.
Okay.
Another significant indication is in cases where there are associated significant rotator cuff tears, particularly full-thickness tears that are clearly symptomatic. In that situation, surgery might be considered earlier to address both pathologies concurrently.
Makes sense.
The dual goals of surgical management are, firstly, to address the unstable and painful non-healing site of the osteochromial itself, aiming for bony fusion or perhaps stable excision to relieve pain caused by that instability. And secondly, to concurrently manage any associated pathologies like those rotator cuff tears or shoulder impingement, which are often present and contributing to the overall picture.
Let's delve into the specific surgical techniques then, starting with open or arthroscopic assisted reduction and internal fixation, ORIF. What's the rationale behind this and how is it typically performed?
Right, open reduction and internal fixation, or IF. This is widely recognized and considered a primary surgical approach for unstable and painful RS acromial fragments, particularly the larger mesoacromial types, that type A we discussed. The rationale is to achieve bony fusion across the non-union site, effectively converting the unstable pseudoarthrosis into a stable, continuous acromion, and thereby relieving the pain caused by instability and impingement.
So turning it back into one solid piece of bone.
Exactly. The procedure typically involves exposing the non-union site. The pseudoarthrosis is debrided, meaning the sclerotic, often unhealthy edges of the unfused segments are carefully excised. This creates fresh, bleeding bone surfaces which are more conducive to healing. Common fixation methods include tension band wires, which provide compression, or cannulated screws, often 2 or more placed across the non-union, to compress the fragments and provide rigid fixation. Sometimes sutures can also be used for supplementary fixation.
And bone graft.
Yes, fusion can also be augmented with bone graft, either local cancellous bone harvested from the adjacent acromion itself, or potentially an iliac crest autograft. Although recent studies suggest there's likely no significant additional clinical benefit from using iliac crest graft compared to a meticulously prepared local bone graft, so the latter is often preferable, avoiding donor site morbidity.
Good point. And what are the key surgical principles for this type of fixation? Are there particular challenges or post-operative issues we need to anticipate with ORF?
A few principles are paramount for success. First, as mentioned, carefully excising those sclerotic, fibrotic edges while preserving as much bone as possible to maximize the surface area for fusion. Then, a crucial technical tip. The anterior portion of the acromion is typically fixed in a slightly tilted upward position.
Tilted upwards, why?
This upward tilt helps to effectively increase the subacromial space. It addresses potential impingement and often makes a separate formal acromioplasty unnecessary. It sort of preemptively deals with the impingement risk.
Clever.
And most critically, preserving that acromial branch of the thoracoacromial artery through a careful transacromial approach is absolutely vital. Maintaining its integrity is paramount to ensure the fragment's vitality and enhances healing potential.
Okay. And the challenges. Hardware issues.
Yes, hardware discomfort is a common postoperative issue, often necessitating a second procedure for hardware removal. This is particularly true after tension band wire fixation, where the wires can be quite superficial and irritate soft tissues. It can be a significant nuisance.
I can imagine.
There's ongoing discussion about using materials like high-strength polyethylene sutures, which might offer comparable biomechanical strength but potentially reduce soft tissue problems, though more research on long-term efficacy is still needed there.
That makes sense. And what about an arthroscopic approach for ORF? What are the benefits there compared to a purely open procedure? Is it feasible?
The benefits of arthroscopically assisted fixation are quite compelling, especially perhaps for smaller or less displaced fragments. It allows for better preservation of the fragment's critical blood supply, as the approach is less invasive, less stripping involved.
Less disruption.
Exactly. It also minimizes deltoid muscle injury by avoiding its detachment from the acromon, which is a significant advantage in preserving deltoid function post-operatively. This can lead to improved cosmetic results and potentially preclude hardware removal if you use, say, absorbable screws.
Absorbable screws, right.
Although the biomechanical strength of those absorbable screws still needs further rigorous research to confirm long-term stability in various loading conditions. But with arthroscopy, you can meticulously debride the non-union site under direct visualization and apply compression using various specialized techniques. It's technically demanding, certainly, but the potential patient benefits can be substantial.
Moving on to fragment excision, when is that indicated? And what are the pros and cons of open versus arthroscopic approaches? You mentioned earlier that open excision for larger fragments is generally discouraged. Why is that again?
Fragment excision is generally reserved for specific situations, typically for very small, often preacromial fragments that are clearly symptomatic, or perhaps as a salvage procedure after a failed ORIF where fusion just couldn't be achieved.
Right.
Now, to your point about open excision for larger fragments, yes, it is broadly discouraged by most authors, and certainly by modern orthopedic thinking. The main reason is a high incidence of postoperative deltoid dysfunction and weakness.
Ah, the deltoid origin.
Precisely. To excise a significant portion of the acromion via an open approach often requires extensive detachment or disruption of the deltoid origin. This can lead to persistent deltoid weakness, sometimes a visible cosmetic deformity, and ultimately mixed and often unsatisfactory patient results. Studies have shown varying outcomes, with some patients having quite poor results after open excision for larger mesoacromial fragments. The deltoid is just too crucial for shoulder function to compromise it unnecessarily.
So arthroscopic excision would be the preferred route if excision is necessary, offering a less invasive alternative.
Precisely. Arthroscopic excision is presented as a superior alternative, where appropriate, largely due to its minimally invasive nature. The benefits include significantly less periosteal and deltoid attachment injury, potentially leading to better functional results and a quicker recovery. Studies have demonstrated patients undergoing arthroscopic excision often show no decrease in deltoid function or strength compared to the contralateral arm.
That's a key advantage.
It is. Furthermore, studies have found no significant difference in clinical results when the excision was performed with or without a concomitant rotator cuff repair, highlighting its versatility. For instance, for a meso-acromiale, a precise bone excision of maybe 5 to 7 millimeters at the non-union site, combined with an arthroscopic acromioplasty, can offer similar results to complete arthroscopic resection of the entire fragment, while preserving more bone. And a major advantage, if needed, a rotator cuff repair can be performed concurrently in the same setting. Comprehensive management.
And finally, what about just arthroscopic subacromial decompression and acromioplasty? When is that indicated for an osacromial patient, and what are the nuances? Is it always sufficient if there's an osacromial present?
This approach, just the standard decompression, is primarily indicated for impingement syndromes, where the osteoacromial is deemed incidental, meaning it's non-tender on examination. The diagnostic injection into the os site was negative, suggesting it's not the direct source of pain, but perhaps contributing to or exacerbating impingement by simply narrowing the space.
Okay, so it's just in the way.
Sort of. However, and this is a crucial nuance and a point of some controversy routine, standard arthroscopic subacromial decompression may not be sufficient for impingement syndrome, truly secondary to an unstable mobile acromial.
Why not?
Because we've seen patients experience symptom recurrence. The standard decompression removes some bone, but it doesn't address the underlying instability of the fragment. That fragment can still tilt down dynamically and cause impingement. This highlights the need for potentially an extended arthroscopic subacromial decompression in these specific cases.
Extended meaning taking more bone.
Yes, involving a more generous bony resection of the mobile anterior acromial tip. The goal is to create adequate space not just for the cuff, but to accommodate that dynamic downward tilting of the unstable fragment. You need to achieve truly satisfactory and lasting results by accounting for the mobile segment, not just treating it like a static spur.
That makes perfect sense. Once surgery is complete, regardless of technique, what does the postoperative rehabilitation typically entail? Surgical success often hinges on good rehab, doesn't it?
Absolutely. Surgical success is truly a team effort, and a structured, progressive postoperative rehabilitation program is critical for optimizing outcomes. It's not just about the surgery, it's very much about the recovery. It typically involves several phases. It begins with protection, often in a sling, and guided passive and assisted range of motion exercises early on, focusing on pain control and preventing stiffness.
Gentle movements initially.
Very gentle. As healing progresses, usually around 4 or 6 weeks post-op for fusion procedures, maybe a bit longer, the program gradually advances to active range of motion, then strengthening exercises. Ultimately, the focus shifts to functional recovery, proprioceptive training, and a safe return to activity, sport, or work-specific movements.
And how long does that usually take?
Patients will typically follow a home exercise program for continued gains. The duration varies, but full functional recovery after fusion, for instance, can often take anywhere from 6 to 12 months. It really emphasizes the need for patient adherence and, frankly, patience.
Excellent. We've covered the what, how, and why, and the complexities of diagnosis and treatment. Now let's look at the bigger picture. What are the typical prognoses for these different approaches, and what are some of the ongoing controversies or future directions in this field?
Well, for patients who respond successfully to conservative measures, the prognosis is often very good. Satisfactory symptom relief is common. Many achieve a full range of motion, typically within 6 weeks of starting an effective regimen, and can expect full functional recovery generally within 3 to 6 months. So that highlights the importance of that initial non-operative trial.
Right.
Surgical outcomes are generally encouraging for appropriately selected patients. Patient satisfaction rates are reported to exceed 85% following successful procedures, particularly with internal fixation aiming for fusion. However, it's important to acknowledge that complete recovery after surgery does take longer than conservative treatment, as we discussed, and absolutely necessitates strict adherence to that structured rehab program. It's not a quick fix by any means.
You've mentioned the debate around ossicromial and rotator cuff tears before. Can you just reiterate the current thinking, particularly for those who might still hold older beliefs? Any newer insights?
Certainly. As we discuss, while those earlier, smaller studies suggested a very high incidence, maybe around 50%, later, larger, more methodologically sound studies found the average number of tendons involved in tears was quite similar in patients with and without ossicromial.
Okay.
This really challenges the broad assumption that ossicromial inherently causes cuff tears in all cases. However, the crucial caveat remains that step-off deformity,
Hmm.
where there's clear inferior malalignment. That specific type is indeed associated with a significantly increased risk of tears due to direct mechanical impingement.
So the shape matters.
The shape and stability matter immensely. This is especially true in young throwing athletes with acromial epiphysiolysis. So the takeaway is, it's not the mere presence, but its instability, and particularly that step-off deformity that carry the higher risk for cuff pathology. A critical distinction for your diagnostic workup.
That's a crucial clarification. Let's talk about another significant scenario. Reverse shoulder arthroplasty, RSA. Is having an ossicromial a contraindication for RSA? Does it complicate things significantly?
This is a very significant clinical point, and the answer is actually quite reassuring. The presence of an ossicromial is not considered a contraindication for reverse shoulder arthroplasty.
That's good to know.
Yes. Studies show that patients undergoing RSA who also have an ossicromial can still achieve good postoperative range of motion and constant scores, comparable to those without the condition. And this is often without performing surgical fixation of the free fragment.
Even without fixing the ossa, why does that work?
It might seem counterintuitive, but there's a plausible biomechanical explanation. The robust attachment of the main part of the deltoid to the scapular spine and clavicle provides sufficient strength and stability. After the RSA, the deltoid's new lever arm and the improved joint mechanics seem to effectively compensate for or overcome the local issue of the unstable ossicromial fragment. Even if that unfused segment tilts inferiorly after the RSA, it doesn't appear to negatively affect the overall outcome. It's very reassuring for surgeons considering RSA in these often complex patients, perhaps with cuff tear arthropathy and an ossicromial.
That's a really important practical point. And what about the relationship between ossicromial and the acromioclavicular joint, the ACJ? Is much known about that connection, or is it an area needing more research?
This area has surprisingly limited published research, actually, which highlights a bit of a knowledge gap. One study did suggest a correlation between the anatomical position of the AC joint and the likelihood of an ossicromial. It found that a greater distance of the AC joint from the anterior edge of the acromion, so a more posterior AC joint, potentially predisposes to an ossicromial.
A developmental link, perhaps.
That was the hypothesis. Maybe a more posterior AC joint alters stresses on the developing acromion. There are also speculative theories about ossicromial affecting ACJ development or maybe contributing to chronic ACJ instability due to altered biomechanics. But critically, there's a real lack of robust published data on any direct association between ossicromial and degenerative ACJ changes, or how an ossicromial affects ACJ stability following common procedures like a lateral clavicle excision for ACJ arthritis.
So more work needed there.
Definitely. More research is clearly needed to fully understand any direct causal relationship or clinical implications in this specific area. It's a fascinating question for future study.
Looking at complications of surgical intervention for the ossicromial itself, what are the most common issues that can arise? It's important we understand the full picture for patient counseling.
Postoperative issues can certainly occur, and it's vital to counsel patients appropriately. Hardware-sourced pain is quite common, as we touched on, often necessitating a second procedure for hardware removal, particularly after tension band wiring. That can be a significant source of dissatisfaction. Variable rates of non-union after internal fixation are reported. Some series report excellent fusion rates, close to 100%. Others report much lower rates, sometimes even 0% fusion in challenging cases. It really highlights the technical challenges, the importance of blood supply preservation, and achieving rigid fixation.
So fusion isn't guaranteed.
Not absolutely guaranteed, no. Infection rates have also been noted, both superficial, maybe around 6%, and deep infections, reported up to 13% in some older series, particularly with certain open procedures perhaps carrying higher risks historically. And of course, persistent pain or weakness can occur, especially after fragment excision, due to that potential deltoid dysfunction if the muscle integrity isn't meticulously preserved.
Okay, a range of potential issues to be aware of. Given these complexities and the areas where evidence is still evolving, what does the future hold for research in osteochromial? Where should our collective efforts be focused?
Well, the pressing need is unequivocally for higher-level evidence studies. Much of the current literature, while valuable, still consists mainly of case series and retrospective reviews. These are inherently limited in establishing causation or definitively comparing interventions. We desperately need appropriately powered, prospective, and ideally randomized clinical trials.
RCTs.
Yes, to more definitively differentiate between surgical interventions, fixation versus excision versus extended decompression in specific scenarios, and to truly inform best practices based on solid evidence. This would help answer fundamental questions about efficacy and long-term outcomes. There's also a strong call for more prospective studies to unequivocally answer whether the osteochromial is directly responsible for a higher incidence of subacromial impingement or rotator cuff tears, moving beyond the current debates based on retrospective data and association. And furthermore, more biomechanical research into newer fixation methods, those biodegradable screws, novel plate designs perhaps is crucial to evaluate their efficacy, stability, and long-term outcomes, potentially reducing that need for hardware removal. These are the areas where we can make the most significant strides.
Professor, this has been an incredibly thorough and insightful deep dive into osteochromial. We've really traversed the complex landscape from its fascinating developmental origins and varied presentations through the nuances of diagnosis and across the spectrum of conservative and surgical treatments. You've truly illuminated this often misunderstood condition.
My pleasure. It's a condition that really warrants this level of detailed discussion. It's crucial for clinicians to keep it in their differential diagnosis.
Absolutely. As we conclude, perhaps consider this. An anatomical variant like ozochromial reminds us that sometimes the most intricate diagnostic puzzles are hidden in plain sight, aren't they? Challenging us to look beyond the obvious impingement label. It really underscores the profound impact a seemingly minor developmental anomaly can have on a patient's function and quality of life, and the critical role of your precise diagnostic and therapeutic skills. It reinforces that sometimes the most complex diagnoses require both a sharp eye and that willingness to dig just a little deeper. If you found this deep dive valuable for your practice and patient care, please do consider rating and sharing Deep Dive Ortho with your colleagues. Your support helps us continue to bring you these in-depth discussions. A tremendous thank you again for your exceptional insights and for expertly navigating us through this complex topic today.
Always a pleasure to discuss it.
Join us next time on Deep Dive Ortho as we continue to explore the cutting edge of orthopedic knowledge.